Well, hello. Thank you so much for coming. I'm Greg Whitman. I'm a neurologist, and I'm going to be talking about dizziness. Since I've been in practice, specialized in seeing patients who have dizziness. This talk that I'm going to be giving today is a variation on a talk that I gave multiple times at Harvard University-sponsored courses for physicians. It's just abbreviated and maybe a little bit less detailed, but you can rest assured that whatever I say is just as authoritative, so hopefully it'll be useful. It is difficult to try to cover every medical disorder that might make somebody dizzy, but we're going to talk about a few of them. I like to define new terms when I use them the first time. And I'll begin with a kind of apology that it's hard to do that for dizziness because it's an imprecise term about which there's a lack of general agreement on what exactly it should mean, and it actually means a multiplicity of different things to different people. But in my experience, most of the time when people say that they're feeling dizzy, they are describing an issue that has something to do with an abnormal feeling in the head. And we can debate exceptions to that, but it seems to be generally true. Abnormalities of perception of one's feeling of position in space or position relative to gravity, acceleration, motion, perception of visual impressions. All of these things can be framed by people as dizziness. A loss of normal postural control, by which I mean the ability to stand normally, to move normally through space. You might think that that's different from an abnormal feeling in the head, and indeed, I definitely encounter patients whose primary issue has to do with mobility or ability to move normally through space or balance, who say, no, my head is fine, it's just that I'm afraid I'm going to fall. And then conversely, or different from that, I encounter people who have abnormal sensations in the head, but really don't have any complaint about their balance. But what I found is that at some point in time, most of these people have both symptoms. So most of the people that have balance issues or walking issues, if you observe such a person over a period of months to years, or if the person thinks back on their experience, that usually it turns out to be the case that if you've got a balance issue, then at some point in time, you'll experience some kind of abnormal sensation in the head. And similarly, the disorders that physicians recognize as causing abnormal sensations in the head essentially all have some impact on balance if you look over long enough periods of time and large enough groups of people. So continuing through the list, vertigo would seem like a somewhat more well-defined symptom. It means an illusory feeling of rotation or movement of the environment. You feel like the room is spinning or moving when other people don't agree. They don't think it's moving or spinning. Instability of the visual scene. So some people have a symptom where walking down the street, it appears that the visual scene is bouncing up and down. That might be described as dizziness. Faintness, or the sense of an impending faint, that's a very common kind of dizziness that a lot of people have had. Almost everyone has had that at some point with enough dehydration or excess exposure to heat or getting up quickly from bed in the morning. But if it's experienced much more than average, then we consider it a disorder. And even anxiety can be described by some people and by doctors as a kind of dizziness. Now, another thing that all of these symptoms have in common is that they all have to do with an absence of normal balance or normal walking or normal stability, standing. So I think it's a good idea when you're thinking about dizziness to think about balance function and how that works. And balance function has kind of a sensory side and a motor side, an input and an output side. So you take in impressions of the world from your multiple senses, from vision, from your inner ear's balance organs, from the feeling of your feet on the floor and others. And you put those all together somehow in your central nervous system in your brain. And then there's a motor output side too, where you generate complex motor programs for things like walking, and your nerves generate firing to cause contraction of muscles, and then you've got the muscles. So there's the whole motor side that's the outflow of behavior that results in things like contraction of muscles and exertion by you of force on the environment. But for the sake of time, I'm not going to talk too much about the motor side of things, but I want to dwell a little bit on the sensory side of the nervous system, the kinds of impressions that you get of the world from your various different sensory organs or sensory systems, from the inner ear, from vision, from feeling, from muscles and joints. And because those all are associated with medical disorders. So neurologists have a thing they do where they try to narrow the list of diagnostic possibilities by figuring out where the problem is. We call that localization. And so faced with a person experiencing dizziness, I like to make a list of systems that might be involved in the person's body. And then each one of those systems has well-known medical disorders that you can look up in textbooks and papers and have diagnostic approaches and treatment approaches. And so some of the systems that one might think about when analyzing dizziness are the inner ear balance system, the visual system, the sensory systems from the muscles and joints, and we'll talk about that a little bit. So I wanted to start with the inner ear. So most people have kind of at least a sense that the ear has something to do with balance, and that disorders of the ear can cause vertigo. And I'm a neurologist, but because of my specialty, since I've been in practice, I've worked very closely with otolaryngologists and neurotologists, and I see a fair number of people that have inner ear problems or inner ear problems and neurology problems, or both, are one affecting the other in both directions. But there's a small set of inner ear disorders that we see all the time in dizziness clinics, in dizziness specialty clinics. So maybe it's worth just taking a minute to talk about the inner ear. So first of all, there can be sometimes a little bit of confusion about the ear coming from the fact that the ear has multiple parts, or there are multiple ears. So there's the external ear, which is the part where you can get water in if you're swimming. And then there's the eardrum, right? And then when your doctor looks in your ear with the otoscope, what they're actually doing is trying to get a glimpse through the translucent eardrum here at the end of the external ear, trying to peer into the air-filled middle ear here, which is beyond the eardrum. And that's really all you can see with the otoscope, is the external ear, and then the eardrum, and then beyond the eardrum, a little bit of the middle ear, which is translucent. And you can see a little bit of the bones in the middle ear that conduct the sound. But the inner ear that has to do with balance is not something you can see. It's deep in the temporal bone of the skull. And it has two main parts. It has a part that's important for hearing, the cochlea, and then it's got a part that's important for balance, the vestibular labyrinth. And the vestibular labyrinth actually structurally has 5 different organs on each side, 5 in the right ear, 5 in the left ear. And so 3 of the 5 are the 3 semicircular canals, which are arranged at right angles to each other and which detect angular acceleration. So that's something like spinning around in a circle or tilting your head backwards. The utricle primarily senses acceleration parallel to the ground. So that's something like what you would feel if you slammed on the brakes in your car. Or the other thing that utricle senses is tilting of the head, because in that case, when you tilt your head, you're feeling the acceleration from gravity. So it's the utricle sensing membrane is parallel to the ground when you're upright, but if you tilt to the side, now it's in line with gravity. So it senses head tilt as well. And then you've got the saccule, which is roughly perpendicular to the utricle and senses vertical accelerations when you're upright. So maybe something like the impact you'd feel of your foot on the ground if you step off a curb. All of these 5 organs have nerves that feed into this vestibular nerve, or vestibular cochlear nerve, which has nerve fibers from both the balance part and the cochlear hearing part. So I guess one thing you could say is that if there's a lesion or a disorder or a disease or a mass that's sitting on the vestibulocochlear nerve, like a vestibular schwannoma, benign tumor, or a meningioma, or maybe even a blood vessel that's exerting some force on this nerve, that you can get some vestibular nerve symptoms. And while I'm talking about that, I guess I'll just address the benign tumors. So benign tumors that sit right kind of here, or more like here, on top of the vestibular nerve, they don't usually cause balance or dizziness symptoms first. They usually cause hearing symptoms first. And in particular, what they cause is an inability to understand words, or what we call abnormalities of speech discrimination. You can have balance symptoms first, but usually then within several months, people develop either tinnitus or hearing problems with using the phone on that side. So if there's a suspicion for a vestibular schwannoma, usually the first thing doctors will want to do is a hearing test. Or in some clinics that specialize in dizziness, they just do a hearing test on everybody. So if you go to some specialty dizziness clinics, you'll find that the first thing that happens when you walk in is they do a hearing test. And that's why, is because they want to exclude the possibility that your problem is that that's one reason why, is that they want to exclude the possibility that there's something pressing on your balance nerve here. And that's going to show up as hearing symptoms that you would see on the hearing test. More common, and while I'm talking about that, I guess I can also mention that there is a kind of attack of dizziness that you can have. And I mention it not because it's very common, but more because it's somewhat overlooked in the United States. It seems to be more recognized in Europe, but occasionally I'll see people that have had some kind of damage to the vestibular nerve. They had a tumor here or radiation or something, and they get these brief attacks of vertigo that last seconds. And in some cases, the person might feel like they've been pushed to one side, or something lateralized like that. Something happens to the right or left, falling, and it's stereotyped, is what we say in neurology, meaning that it happens the same way over and over and over again. It's like identical episodes. And when people have those kind of very brief, stereotyped episodes of imbalance or dizziness, it makes us think a little bit about something pressing on, damaging, irritating the vestibular nerve here. And that could be almost anything that exerts pressure or causes damage on the vestibular nerve. And that could be a hard diagnosis to make, but it's out there, and we treat it with medications, and so it's overlooked. So there are a lot of things that are kind of rare ear disorders that I don't have time to discuss them all, but I think it's nice to discuss certain things that are treatable and not vanishingly rare, and also kind of overlooked. So that's one of them. That's called vestibular paroxysmia. While I have this picture up, I think it's worth talking a little bit about the utricle. That's that organ that would get deformed and sense acceleration if you slam on the brakes in the car, or if you hit your head on something, which means that your head suddenly stops. So that's a kind of acceleration, deforms this membrane. And what can happen is the sensors are these hair cells, we call them, and they're embedded in this membrane, and the membrane gets deformed if you hit your head. And there are these little otoliths that are calcium protein complexes that give the system some weight and help you detect the acceleration, but they can break down and little pieces of them can be degraded and float off of here, and then they're floating around in the fluid of the utricle. And once you've got debris floating around in the utricle, kind of like snow in a snow globe, what can happen is that it can be transported into one of the semicircular canals. Like most commonly what happens is it floats into or makes its way into the posterior canal, and then the snow in the snow globe is now trapped at the bottom of the posterior semicircular canal. And that is an extremely common cause of what's called benign paroxysmal positional vertigo, or BPPV, which I have a slide on, but that wouldn't be surprising if at least one person in this room has had it, because we see it all the time. But that's where it comes from, is that we think that it's typically in the utricle that some otolith debris is released from the utricular macula, that thing is called, and then the debris is floating around the utricle. Maybe the person gets their head into kind of an upside down position, like getting your hair way back at a hair salon, having your hair washed, or maybe bending over or something like that. And then you get back up and the debris floats into this canal, but then once it's in here, it gets trapped at the bottom of the canal. And this drawing here is in an upright person, right? And when the person is upright, the debris in BPPV is typically trapped at the bottom of the canal here, and it's hard to get it out unless you undergo a particular series of motions, which we do deliberately to cure it, which we could talk about. There's actually a whole separate video on the Hoag Health channel that's about BPPV. You could learn more about it there. But moving on, so BPPV, as I mentioned, it happens when this otolith debris gets trapped in, could be any of the three semicircular canals, but most commonly it's the posterior canal. And we recognize this syndrome because patients say that they have episodes of dizziness, and the dizziness is positional. And so typically it's triggered by lying down or rolling over in bed, or looking up, like to get something up off of a top shelf. So that's positional. So we say it's positional vertigo. That makes us think about this disorder. But I think it's important to point out that although patients with BPPV, which again is very common, have these episodes of positional dizziness it's the more marked kind of dizziness that these people have, the same patients typically also have less well-defined constant symptoms. So a little bit of imbalance while walking, a little bit of hard to describe lightheadedness, and that often is a source of confusion. So a lot of times patients will discuss the symptoms with one of their doctors, and they'll reach a consensus that it can't be BPPV because it isn't positional, that the symptoms are present when you're just sitting or walking, and it's not that patients with BPPV can't have non-positional symptoms. It's just that they do have positional symptoms, or have at some point had positional symptoms, and those are the more striking ones. So that's an important point. Sitting up does tend to trigger the symptoms, the dizziness, but sitting up triggers a lot of types of dizziness, so that's somewhat less specific. We're probably mostly going to do questions at the end, but we'll take this one question.
Okay. I was just wondering about, so if that debris...
So the question is, what if the debris never makes its way out of the semicircular canal where it's trapped? And and then would you continue to have symptoms? And I think the answer is yes. So if you wait long enough, a lot of patients will spontaneously enjoy resolution of their symptoms. And we think that that is because, at least in part, because people turn over in bed, they get in and out of bed, and they accidentally move the debris around the inner ear, and eventually it makes it out of the semicircular canal where it was trapped. And then once it's back in the utricle, we think it resolves somehow. It either gets reabsorbed or cleared or something. But the problem is that in some people, it is really hard. It doesn't clear. So I have seen people that have had it, I thought, for several months, 8 months, 9 months, a year, and it's always hard to be sure. If you meet somebody for the first time and you're never sure if the symptoms were really continuous for the whole 10 months or whatever it was, or whether there was a break in symptoms that maybe reflected temporary resolution where the debris either got out into the utricle and then went back into the canals, or maybe there was clearance of the debris, but then more broke down off the utricular macula. But I do think that there is a small subset of people where it really doesn't clear for long periods of time unless you treat it with. So I guess we can talk about treatment briefly. So, and again, there's a video on BPPV on the Hoag Health channel you can check out. But the Epley maneuver is the most commonly used maneuver for treatment of posterior canal BPPV. And that involves simply turning the head to one side, having the person lie down toward that side, turn to the opposite side, turn further, and then sit back up. And all you're doing is just turning this canal and moving the debris around the canal and dumping it out into the utricle in a very systematic way. And that works. If the debris is trapped in one of the other canals, the maneuver you have to use is different. So if it's trapped in the horizontal canal, there's a different maneuver that involves just lying on your back, turning on your side, turning further onto your stomach, continuing to turn so that ultimately you make a 360-degree revolution and end up on your back. And you do that multiple times and that clears it. If it's trapped in the third semicircular canal, which is called the anterior canal, there's yet another maneuver it's called a deep head hanging maneuver, where you just lie all the way straight back really far so your head is hanging backwards. And so the best thing to do is to find some healthcare provider that's familiar with these variants and nail down which type or types of vertigo you're dealing with, or BPP you're dealing with, and then use the appropriate maneuvers. And sometimes you have to do one type of maneuver, and then later do other types and keep working on it until you eventually clear things. I don't know if that answers the question. I think it does. So these are some things to keep in mind when a person tells me, I keep waking up with vertigo. The majority of the time, that's what this is. It's BPPV. Dizziness upon lying down is, I won't say always, but it's almost always BPPV. When people say they keep having vertigo, and again, vertigo, it means one feels like the room or the environment is moving or spinning. It's happening in episodes. It's recurrent. It's happening over and over and over again. There are different disorders that can do that, but this is one of the top ones to think about. The acute phase or the beginning period of time when one develops, this can be disabling. So sometimes people can't get out of bed at all because they're just too dizzy and sick. And so it sort of almost invalidates the designation as benign paroxysmal positional vertigo, because if you can't get out of bed at all because you're too sick, that's not very benign, that people can't leave the house. So that's another source of confusion, that sometimes people who are that sick and can't get up are thought to not have BPPV because it's supposed to be benign, but isn't always that benign. I mentioned that you can have some constant, harder to describe symptoms in between the positional vertigo episodes. It's important to recognize that BPPV aggravates migraine. So sometimes patients will actually come into my clinic complaining of migraine or vestibular migraine, which I'll hopefully talk about. But it sometimes is the case that the underlying trigger or the thing that's driving the migraine is this, and that it needs to be treated before you can get anywhere with migraine medicines and other migraine approaches. After you treat BPPV, you may no longer have bursts of well-defined vertigo on lying down or rolling in bed. You may no longer have eye movements that the doctor can recognize, which is how we make a diagnosis, by the jumping eye movements or nystagmus that you have when you lie down. But you can still be off balance and a little bit dizzy for a period of several weeks or sometimes months. So that is important to recognize as well. There's a post-BPPV syndrome. You can see the posterior canal here, the debris is trapped at the bottom. It's hard to get it out of that canal. When the person tilts their head back, this is the new configuration. So this is what happens if the person looks up to get something off of a top shelf, or maybe lies down. It's the same kind of motion, the head is tilted backwards. What happens is that the debris gets picked up so that now it has the opportunity to settle down under the influence of gravity. And what exactly happens there physically is a little bit unclear, but maybe it's like a syringe where as the debris settles down, it creates not a vacuum, but a low pressure of the fluid here that pulls on the sensor in the canal, something like that. So the fact that there's debris in there, it creates this situation where getting into certain positions relative to gravity allows that debris to settle, again, like snow in a snow globe. But the settling of debris in this very extremely narrow tube creates pressure effects that wouldn't normally be there, and pulls and pushes on sensors in here, and ultimately causes that vestibular nerve we were talking about to fire in abnormal ways that convince the brain that the person is moving when the person is not, and that could be very disorienting. So I mentioned before that the way you diagnose BPPV is that an examiner, some healthcare provider observes a burst of abnormal eye movements. If it's the typical posterior canal variant we've been talking about, then the eyes go up and down and turn. It's called torsional upbeat nystagmus. Contrasting with that is the horizontal canal variant, where the debris is trapped in the horizontal canals that we discussed briefly with the question earlier. That one looks different. So if your doctor or another healthcare provider does some of these positional tests where they have you lie down in different positions, they may say, oh, that, I see something unusual where the eyes are moving right and left, horizontal nystagmus. That can be because the debris is in a different canal than the most common one. And as I mentioned, the treatment is different. Anterior canal, same thing, there's a different kind of eye movement. So in posterior canal BPPV, the most common type, the vertical eye movement is upbeat. So that means that the eyes drift down and then jerk up. So it's kind of has like an upbeating appearance. Slow down, fast up, slow down, fast up. If the debris is in the anterior canal, it's the exact opposite. The eyes drift up and then jerk down. So that's called downbeat nystagmus. So it's kind of like this, slow up, fast down. So your doctor can recognize that, or physical therapists, if they're trained in this, can recognize that, and they can adjust their treatment. Switching gears, I'll talk briefly about Menieres disease, or Menieres syndrome is a degeneration of the inner ear. The exact mechanisms and causes are unclear, but we recognize this syndrome that consists of episodes of severe dizziness, typically whirling vertigo, that are prolonged. So these patients typically have had at least some episodes that last an hour or more. It's really miserable, kind of prolonged vertigo attacks with a lot of nausea and throwing up. And the way we make the diagnosis usually is that we do a hearing test and we identify hearing loss for low-pitched sounds in one ear or asymmetric in one ear more than the other. That's kind of the thing that clinches the diagnosis, the combination of asymmetric, low-pitched sound hearing loss and prolonged attacks of vertigo. And we recognize that that seems to be due to a degeneration of the inner ear structures, the saccule and other structures, cochlea. So I mentioned that the way you get this diagnosis is that the hearing test is asymmetric. So like, for example, maybe the left ear has a severe low-pitched sound hearing loss and the right ear is fine. Because asymmetric hearing loss can also be due to, like I was mentioning before, a benign tumor sitting on the balance and hearing nerve. If the doctor sees asymmetric hearing loss like that, usually they'll want to do at least one scan with contrast, if possible, of the ear region. So like an MRI of the internal auditory canals with contrast. So that's another thing that may come up if you're dizzy and see a doctor, is they may want to order an MRI of your head and the ear region, the internal auditory canals. And the reason is that they want to know, again, is there a mass pushing on the hearing and balance nerve? But it could be that if you have asymmetric hearing loss, it's because of Menieres disease. If you're early in Menieres disease, you'll typically see this low-pitched sound pattern where hearing is relatively good for higher-pitched sounds, but really poor for low-pitched sounds. But later, or in older people, sometimes we see a more what we call flat hearing loss, where the hearing loss is pretty significant across all pitches, and then it can be harder to recognize Menieres disease. But as long as the hearing loss involves low-pitched sound or involves the low frequencies, then you may be a candidate for this diagnosis. So this is what the hearing test actually looks like in some patients who have Menieres disease. So the way hearing tests work is they typically, the audiologists will plot out how loud do they have to make the sound at different pitches for you to hear it, and to raise your hand or push a button and say, oh yeah, I hear that tone. And so they typically plot out the low-pitched sounds on the left, and then the higher-pitched sounds at progressively further positions toward the right. And so what you're seeing here is that at low pitches of sound that are presented to the patient, they had to make it really loud for the person to hear it. But when they got up to higher pitches of sound, the person did fine, and that they were able to say, yes, I hear that, with quieter sound. So this is a Menieres type audiogram, and you can see the opposite side is fine. I was mentioning before that when you have asymmetric hearing loss like this, that there's always this differential diagnosis or a list of diagnoses that ear, nose, and throat doctors anyway go through automatically always, that they ask, well, could this be a benign tumor on the hearing and balance nerve? And one of the ways that they look for that is they look for impairment of word recognition or speech discrimination, where the audiologist reads a list of words and you have to repeat back what the word is. And if you have really severe pure tone hearing loss of any kind, where they have to make it really loud for you to say, yes, I hear it, then you're also going to have trouble with word recognition, right? But people who have these benign tumors on the hearing and balance nerve, they typically have impaired speech recognition that's out of proportion to their ability to hear just a tone. So the way you can capture that in a compact way is by saying that the pure tone hearing, or the pure tone average, is the thing that they compute should be similar to or somewhat close to the speech recognition threshold, which is how loud they have to speak words for you to hear them. So if they only have to make the sound kind of moderately loud for you to hear it, but they have to make speech really loud for you to understand it, then there's a significant problem with speech recognition, and they have to do an MRI. It's that kind of analysis. I mean, diagnosis has to be individualized, but that's kind of the process that doctors go through. I mentioned vestibular schwannoma is a benign, very slowly growing tumor, typically not an emergency to do anything about, but you need somebody to follow up on it. You can have other tumors in that same location. You can have a meningioma, you might have heard of, as a very benign, usually kind of tumor, can cause the same syndrome. But if it isn't a tumor, if it's Menieres disease, meaning a degeneration of the inner ear, causing prolonged attacks of vertigo and this asymmetric hearing loss, what do we do about it? We typically are pretty good at controlling the attacks of vertigo. And the first line of treatment, the first thing we prescribe usually is limiting and spreading out the consumption of dietary sodium over the course of each day. So typically doctors will say, try to keep your dietary sodium down to 2,000 milligrams a day or less, something like that. And that's hard. I mean, you might think that doesn't sound like a lot, but if you start adding up the milligrams of sodium that you can identify from packages of things that have labels with sodium, or Googling things, you might actually be taking more sodium than you think. But my point was that in addition to the total daily sodium, it's very important, we think, or some people think, to spread out the sodium consumption over the course of the day. So if you have practically no sodium all day, and then you have a dinner with a big load of sodium, 2,000 milligrams all at dinner, then a patient with Menieres disease is liable to get an attack of vertigo, or it is at risk of getting an attack of vertigo. So we try to get people to spread out sodium, drink more water, limit caffeine and alcohol. And when that doesn't work, there are medical treatments. There's pills. Sometimes the ear doctors will inject a corticosteroid medication into the middle ear, hoping that it'll leach into the inner ear through the oval and round windows, which are windows between the middle and the inner ear. And all that stuff works pretty well. We can usually get control over this stuff. There are surgeries that ultimately some people have the balance nerve cut to eliminate the abnormal signals that are going from the ear into the brain. But that's a very last resort kind of option. Like less than 1% need that. So if anybody ever has a family member or something where they come in for the first time to a doctor and they say, "Oh, you have Menieres, we're gonna cut your balance nerve." No, that's not the first line treatment. That's a last resort option. Most people don't need surgery. Some people gradually or not so gradually lose the balance function of both inner ears. And although that can cause attacks of vertigo, especially if it happens asymmetrically along the way, in most cases, the syndrome is the instability of the visual scene I was mentioning, like the bouncing up and down of your impression of the environment as you walk, or vibrating of road signs when you look at them out of a moving vehicle, or other instability of the visual scene, and then imbalance while walking, especially walking in the dark, can be very difficult. The good news is over time, a lot of people adapt pretty well to this. And maybe it's worth pausing for a moment and just talking about the multi-sensory nature of balance function. So I was mentioning at the beginning of the talk that that's my usual framework for generating a list of diagnoses, is which systems could be involved that impact balance. And there's several of them. So what happens is your brain has to integrate information from these 5 vestibular inner ear organs I talked about in each ear, and then maybe hearing it helps balance. That's under investigation actively now. And from other places too, muscles and joints, and your brain has to put all this stuff together. The good news is, even if you lose some of these functions, like you have one of these disorders that I've listed here, like you have a almost total loss of inner ear balance function from exposure to tobramycin or gentamicin, or you have Lyme disease, or for unknown reasons maybe, which is the most common case with bilateral or both ears loss of vestibular function, is of unknown cause. That's the most common situation. But let's say you completely lose, or you almost completely lose your inner ear balance function in the ears. You could still recover pretty well, at least to the extent that many people can walk. It may not be perfect, but you can walk, which is kind of surprising when you think about it. Or you can be blind and you can walk. Or you can have complete numbness almost of your feet and not know where your feet are on the floor, and you can walk. So that's the good news, in a way, is that there's a kind of redundancy in the overall multisensory balance function. There's a redundancy in that you're getting information from multiple different types of sensation. And so if you lose some of the sensory input or sensory channels, you can still kind of do okay. The bad news is that to be kind of like, if you pick an arbitrary activity, like let's say professional tennis, and you want to be a champion at it, you kind of have to have everything perfect. If you really want to be at the highest top of your game in some arbitrary physical activity that you pick. And the flip side of that is that if there's any problem, I lost my slide, if there's any problem with any of these systems, or with the brain or the spinal cord, which puts the impressions together and integrates them, problem anywhere, that's going to translate into some medical disorder and some person somewhere that's going to have some issue with it, with their balance function or with dizziness related to some aspect of sensation. Hope that makes sense. So there's a multisensory strategy that human beings have for balance is good and bad. It's good in that it's redundant. You can recover from losses. The bad thing is that if everything is imperfect, then it's hard to be perfect at an arbitrary physical activity. Another extremely common thing that we see in dizziness specialty clinics is vestibular migraine. So I guess we could start with migraine is extremely common. So the estimates of the frequency of migraine in the general population is somewhere between 5 and 20% of people have migraine. Maybe it's about 15% these days, people are saying. And what is migraine? Well, migraine means that at some point in your life, you've had some headaches that either came with nausea or came with excessive sensitivity to light or sound. But the thing that a lot of people don't realize or forget is that you can have migraine is a lifelong disorder. It's something about your brain, your brain's electrical chemical function. And it's there for your whole life, but you can go many years without having much trouble with it or any recognized trouble with it. So even if you had your few migraine headaches with nausea and light and sound sensitivity 45 years ago, that still counts, and we still say you have migraine. So that's migraine. Vestibular migraine means that you also have dizziness, and that we think that the dizziness is due to the migraine disorder. That's basically what it means. And there are operational criteria like you should have had so many attacks over so much time, and the attacks should have gone with either headache or nausea or light sensitivity or something like that. Those are operational research criteria that are being used to study this stuff. But basically what we're saying when we say you have vestibular migraine is, number one, we think you have migraine. The symptoms may have been like 48 years ago, the symptoms that allow us to make that diagnosis. And you have dizziness, and we think the dizziness is related to your migraine disorder. It's extremely common in dizziness clinics. And so, and to some degree, it's a diagnosis of exclusion because sometimes it's very hard to recognize the co-occurrence of dizziness and migraine symptoms in the same person. I mean, even if you know someone has migraine, that doesn't prove that any dizziness they ever get is due to their migraine. So what you really like to see as a diagnostician is a person who reports dizziness has had their dizziness along with excessive light sensitivity or along with a visual disturbance or maybe right after some visual disturbance where the person saw flashing lights or something like that. But you don't always get that. So sometimes we have just kind of a suspicion that their dizziness is related to migraine. And so sometimes we'll use non-committal terms like possible vestibular migraine. And ultimately, we sometimes just have to try migraine medications and see if the symptoms go away. A couple of points that I think deserve emphasis. I mentioned before that some patients who present to my clinic with migraine actually have unrecognized benign paroxysmal positional vertigo. And once you cure the BPPV with these physical maneuvers, then the migraine symptoms abate or go away, and there's often no need to add migraine medication. So I'm always thinking if somebody comes in to clinic with headache and dizziness, that maybe there's an underlying BPPV here that needs to be fixed. So before we start giving daily prescription migraine medicine, we should figure that out. Similarly, obstructive sleep apnea, which probably you all by now know what that is, where a person repeatedly stops breathing over and over again for a period of seconds at night, and the oxygen level temporarily drops, and the person wakes up. They don't get any sleep. They're up all night waking up and may not even realize they're waking up. That is a very strong trigger of migraine. So sometimes people will come in with dizziness or headaches or both, and the underlying driver or trigger is actually sleep apnea, and you treat the sleep apnea and everything else gets better. So that's an important one to monitor or be aware of. I wanted to mention, because it's very common and also, I think, commonly overlooked, dysautonomia. So the word dysautonomia just means dysfunction or malfunction of the autonomic nervous system, which has parts in the brain and the nerves and distributed throughout your nervous system. The autonomic nervous system is the part of the nervous system that regulates all the automatic functions that you don't have to think about, like blood pressure and heart rate or pulse and blood flow to different places, digestion, breathing. That's the autonomic nervous system. If something isn't working with the autonomic nervous system, we call that dysautonomia. And one of the key symptoms of, or key forms of dizziness that we see in dysautonomia is lightheadedness in upright postures. So the way we recognize this usually in clinic is people say they feel relatively better, maybe not perfect, but feel relatively better lying down, but upon sitting up, or commonly upon moving from a sitting to standing position, or upon prolonged standing, like waiting in line or talking to someone, or maybe in heat, or maybe first thing in the morning, that's another at-risk time, the person begins to feel lightheaded. So it's that positional dependence, or dependence on prolonged motionless standing in one place when gravity is trying to pull blood away from your brain, or with the stress of heat. It's that what we call orthostatic lightheadedness, the lightheadedness you get when you're standing up, that gets us thinking about this diagnosis. If we recognize this kind of syndrome, then we usually want people to see a cardiologist at least once to think about the electrical system of the heart, rhythm abnormalities where the heart goes too slow or too fast or doesn't pump effectively, or coronary artery disease where the heart's not strong enough because the blood flow in the arteries, the heart's not right. But the majority of people anyway that I've seen in dizziness clinics who have orthostatic lightheadedness or dysautonomia go to the cardiologist, and the cardiologist says, nope, the heart's fine, it's not the heart, send them back. So in many cases it seems to be not the heart, but the nervous system's regulation of the cardiovascular system, the nervous system's regulation of blood flow, heart rate, blood pressure, that's really at issue. And these are important people to recognize. These are patients that tend to fall between the cracks in the medical system, because the cardiologists, some cardiologists are interested in dysautonomia, others are not. It's not their thing, and so they'll, like I say, send them back. Most neurologists are not that focused on dysautonomia. Fainting is generally, I shouldn't say generally, but often thought by neurologists to be more of a cardiology, internal medicine kind of an issue and less of a neurology issue, fainting, or syncope, we say technically. But it may not be. It may be something with the nerves or even the brain. So brain diseases can affect the autonomic nervous system. In many cases, it's of unknown cause. In some cases, it seems to be post-viral, that people are doing just fine, maybe very active physically. A lot of them, I think, are active physically for a reason. So some people seem to be predisposed to this, that have lifetime tendency to feel lightheaded upon getting dehydrated or in the heat. And a lot of those people I found have a kind of a habit of exercising or even being competitive athletes, and it may be because being a competitive athlete, it tones up your autonomic nervous system and helps you keep blood circulating to the brain. And so sometimes something will happen to these people though, like they'll either have an injury and be laid up and lying in bed for a period of weeks and get deconditioned, and they'll develop this. Or they'll be fine and then they'll get hit with a virus. Like, I don't want to start naming viruses because then people are going to think they have them. But so there are some people that seem to be just fine, perfectly healthy, and then they get hit with a viral illness, and then they develop a dysautonomia. And the exact mechanisms of that are somewhat debatable, but it can happen. Vitamin B12 deficiency can be responsible for this concept of ocho. So this is Peter Novak, who's an autonomic neurologist in Boston that I worked with for a short time, and he's a very creative guy who's his whole career is about dysautonomia. And so he came up with this idea of ocho as like orthostatic cerebral hypoperfusion. So hypoperfusion means not enough flow. Okay, so this orthostatic means when you stand up, cerebral is the brain, hypoperfusion is not enough blood flow syndrome. And the idea is that most of the time, dysautonomia, if it's diagnosed in a laboratory, and usually it's not, but when it is, it's usually using something called a tilt table test, which is where they have you relax and lie down for several minutes or more and monitor your vital signs, and then they stand you up or almost up, tilt you up on this table to 70 degrees, and then they watch for some period of time, 10 minutes, 30 minutes, 40 minutes, maybe longer. And what they're usually looking for in tilt table tests primarily is temporary or not so temporary drops in blood pressure or heart rate, or maybe escalation of higher heart rate. And these things allow them to make a diagnosis. But there are some patients who don't have any blood pressure or heart rate changes in the tilt table lab, but they still feel very dizzy when you tilt them upright. So Peter Novak set up, I think in multiple labs now in Massachusetts, a setup where in the tilt table test lab, they also did brain artery ultrasound, transcranial Doppler ultrasound, TCD, and demonstrated drop in blood flow in a subset of people with cerebral, with orthostatic lightheadedness who didn't have blood pressure and heart rate changes. So I guess what I'm trying to say is that just because your doctor has you stand upright in their office, or maybe even they do a tilt test, and your blood pressure and heart rate are stable, that it doesn't necessarily mean that you're getting enough blood circulation to your brain. And so one of the ways we know that people are not getting enough blood circulation to their brain is they say, whoa, whoa, I'm getting dizzy, right? They report it. They say, you can tell because people say they're starting to feel dizzy and faint, and also sometimes vision becomes blurred and cognition is affected, so people have a little trouble paying attention. These are all manifestations of drop in blood flow. So I guess in the office when I'm seeing patients, the two most common things that I'm looking for that are helpful clinical signs that are lightheadedness when a person stands up from a chair. That's really quick to check at home or in an office. And if people have it, there's probably something going on. Could be as simple as you're not drinking enough fluids, right? I mean, you might not have a recognizable disease and you're just dehydrated and your system requires a little bit more fluids. But yeah, lightheadedness when you stand up from a chair is important to look for. And then the other one is if a person stands motionless for a few minutes, do they begin to feel progressively lightheaded, inattentive, develop blurred vision? Those things are very helpful clinical signs that you can figure out in a few minutes and get closer to this diagnosis. And even if the blood pressure and heart rate are stable, you might still have it. All right, I want to say a few words about this idea of cervicogenic dizziness. So the idea of cervicogenic dizziness is that somehow you're getting dizzy because of problems with your neck. And there are a number of different ways that could happen. But I guess the thing to realize is that the neck has nerves that provide the brain with cues about position and motion of your head. So when you turn your head to one side, you're stretching receptors on one side, and you are also aware that you generated that motor command, and so that's important. And so the neck has position sensors and stretch sensors. So we know that there's a biological substrate to believe this is true. This is a controversial area of neurology. Like, there's not general agreement on how do you diagnose this, so that's why I'm spending a little time about trying to build an argument for like why there should be cervicogenic dizziness. There should be such a thing as cervicogenic dizziness because the neck has sensors of position and motion, and if those get messed up, then of course you're going to have some kind of dizziness based on everything else we just talked about. So there should be such a thing. Pain specialists that inject facet joints in the neck do this because people sometimes have neck pain, and it's because of presumed inflammation in these joints between the adjacent vertebral bodies. Those are called facet joints. They'll inject medicine. pain medicine, anti-inflammatory corticosteroid medication in these joints. But a lot of them will avoid injecting the facet joints on both sides, because then you're knocking out the sensation from those joints of how your neck is moving, and some of those people get dizzy. So that's further evidence that you should be able to get dizzy because of problems in the neck. I think it's challenging to make a diagnosis. One of the things that we try to do is just turn the neck to the extremes of position in the office when we're examining people in different directions, and see if that makes the person dizzy. And then, because when you turn the head, you're also stimulating the inner ears, you can change the positions of the inner ears relative to gravity anyway, by having the person lie down and turn their neck in different positions, and try to convince yourself whether you can provoke dizziness by certain kinds of neck motion. And what do you do about that? Well, all you can do is try to figure out what's wrong with the neck and get people adequate treatment. So typically it's physical therapy or some kind of injections. If people have really severe problems with their neck, sometimes they need to see spine surgeons, but it's that kind of range of treatments. It's almost the same range of treatments that is available for other forms of neck disorders that cause pain and stiffness and weakness. So that's out there. Vision is an extremely strong cue for how you're moving in the world. So I don't know if you can really see this, partly because there are these lines going across and flickering, but I don't know. When I look at this picture, I have a kind of a sensation of flying or moving over the landscape. I don't know if you get that or not, but vision's a very strong kind of stimulus, and it's a very strong cue about how you're moving in the world. And because of that, if any of that processing of visual information is imperfect, it's probably going to arise dizziness or cause dizziness in some people. And so sometimes we think about this in terms of visual dependence, where it's always the case that your brain has this kind of choice of all the different sensory channels to pay attention to, your inner ear, your vision, as we talked about. And your brain has a choice to decide how seriously to take each of these different sensory channels. Like if you're walking and you tilt your head a little bit and you have benign positional vertigo, hopefully you're not going to take too literally the sense of spinning of the world, because you may fall over. So you have these other sensory channels, vision and your feet on the floor, that are able to inform your brain that no, you're not spinning, and make adjustments accordingly. But some people get very dependent on vision, and the brain, for some unknown reason, decides to put a lot more weight than it should on visual cues, such that something moves into your environment one way, you think you're moving the other way. Like a normal example, I'm sure everybody's experienced at some point, is vection, where you're next to some large moving object in your peripheral vision. Like you're parked in your car and there's a large truck next to you, and you feel like you start to go backwards. It's a very powerful illusion. You look up and you realize, oh no, there's something next to you that's moving forward. You're not actually literally moving backwards, but you almost can't be convinced otherwise. It's such a powerful illusion. Some people experience stuff like that all the time, where they walk past a pattern, like I don't know, some kind of wallpaper or pattern in the environment, floor, and their brain takes it very literally and it throws off walking, because it's a kind of a maladaptive use of cues to navigate the environment. What do you do about this? It's hard to know. I mean, like with everything else, we try to give people diagnoses that have accepted criteria. Some of those are migraine, we talked about. Migraine seems to, in many people, cause enhanced sensitivity to visual patterns, visual movement. So sometimes, if that becomes really excessive, you can treat for migraine and it may improve. Anxiety disorders seem to be associated in some cases with enhanced sensitivity to visual patterns of visual motion. So sometimes a psychiatrist or other provider can treat an anxiety disorder and help with this. one form of visual dependence is this thing called Malte-Debarkman syndrome. And actually, Malte-Debarkman syndrome, or MDDS for short, it is not defined in terms of the visual dependence, but just based on my experience, which is more than most people's experience with MDDS, I believe it's a fairly constant, or at least common, feature of MDDS to be somewhat visually dependent or excessively sensitive to visual patterns or visual motion. But the defining features of MDDS actually are fairly continuous feelings of motion, like rocking, that typically, or at least classically, are triggered after some unusual exposure to motion. Like the classic thing is a person goes on an ocean cruise, they come back and they still feel like they're on the boat and still feel like they're rocking. And a little bit of that can be normal. A lot of people have had that for a few minutes, a few hours, maybe even a few days. It goes away. We kind of consider that normal. But if it goes on and on for weeks or months or years, we consider it a disorder, and we call it Malte-Debarkman syndrome, or MDDS. It can happen after a flight or a long road trip, or actually a number of other kinds of unusual motions. Like I've seen it after extended practicing in a sport where the person was repetitively undergoing the same motion over and over again. I've even seen it in after inner ear disorders, like after benign positional vertigo, where the ear is telling the brain that there's an unusual form of motion going on. The brain then processes that signal and does something abnormal and decides that the world should always feel like it's rocking or moving. That's Malte-Debarkman syndrome. These are people that come in saying, I feel like I'm constantly rocking, I feel like I'm on a boat, and it can throw off walking, or it may not much, but if you look carefully enough, it probably does. This is a very challenging syndrome because we don't have great treatments for it, but actually the one form of treatment that's been validated by clinical trial is a visual treatment. So I'll show you a picture, but it involves using visual cues as a kind of a tool to manipulate the balance system. So I mentioned before, these guys in New York at Mount Sinai got the idea that maybe they could use visual stimuli as a tool to manipulate the balance system. And so they have this lab in the basement that's been run kind of curiously by PhD physiologists under the supervision of the neurology department. And you can't really see this picture very well, but basically what you're seeing here is a dark chamber where stripes are projected on the wall, big stripes, that like floor to ceiling kind of stripes, either vertical or horizontal, and the stripes move. So horizontal stripes that move up or down, and vertical stripes that move right or left. And they came up with this paradigm that also involves moving the head back and forth in certain ways. And there's a whole theory about it, about how it readjusts how the ear and the brain work together. And that's, you know, something that we debate. But the important takeaway, I think, is that this is an example of use of visual stimuli to manipulate, recalibrate, maybe normalize vestibular balance function. And there's not much of this going on. Indeed, I'm not sure if there's any place in the country now, except for this lab in New York, that's routinely doing this. There are a couple of other places that are experimenting with similar idea using virtual reality goggles, like the Oculus Rift or similar, to present so-called full field stimuli, where it's the equivalent of like floor to ceiling stripes or something. But I don't think they're doing it quite the same way that they did in New York. So this needs more research to figure out what's going to work or what's not. But one thing I could say for sure is that vision taps into the balance system in very powerful ways, and eventually it's going to be some kind of a treatment. I wanted to briefly mention something about the role of attention in balance or cognition. So standing, balance, walking require a certain amount of thinking or cognition. And so many people have had the experience where a fall occurred when the person was distracted, was trying to talk to someone or was thinking about something else and fell. That's very common. because balance requires a certain amount of attention and thinking. And so it's also the case that if you have a cognitive disorder, some kind of a brain disorder that has been framed mostly as a disorder of attention or memory, you may also have balance issues. And like I was trying to, I don't know if I articulated this well or not before, but that balance and dizziness are kind of intertwined. So there are people that have predominantly balance disorders and predominantly dizzy in the head disorders, but most people who have one of those have a little bit of the other one at least at some point in their disorder. Well, this is yet another example that, so another kind of dizziness is the person primarily has a cognitive disorder that affects memory and attention, but as part of that, there's also an associated balance and gait disorder, and as part of that, there may be a smaller dizziness kind of component. So that's how it made it into this slide deck here, but I think it's important because people that are having problems with their attention or cognition or memory are at an elevated risk for falls. So when you are doing something challenging, like walking up and down the stairs or walking in the dark or walking near curbs, you have to really pay attention and devote your full attention to navigating the challenging environment. And that will help lower your risk of falls. Also, your doctor can work on attention by reducing the amount of sedating medications that may be dulling your mind and not letting you pay attention to your surroundings. Some of those may not be necessary anymore, or they may be necessary and the dose can be reduced. So a lot of what we do in neurology is looking at medication lists and trying to de-intensify or lower the dose of medications that may be inhibiting brain or other nervous system function. And this is an example of that sometimes people are on sleeping pills and other psychiatric medications and on long lists of meds, and it impairs brain function and it can throw off your balance. And so that's part of what we do. You can sometimes do non-drug there are non-drug approaches to improve your attention. Exercise probably does something for your attention. Meditation and yoga, things like that, may help focus your attention. So you can work on those and enjoy some benefit in terms of balance and walking. And I just, I'll mention briefly that another sensory system that we haven't talked about much is hearing. So it's generally thought to be not a huge contributor to balance in humans, but you do sort of move through a soundscape and get cues from the environment about where you are, how you're moving, that are based on the impressions of sound waves bouncing off the walls and floors and your environment. And so there's some early research on the difference between hearing aid users when they have their hearing aids off and when they have their hearing aids on, and hypothetical improvement in balance with use of hearing aids. So it looks like we're needing to wrap up. There may be another talk coming into this room, but I think this is another interesting and somewhat neglected area of neurology, is that to what extent does your hearing contribute to your balance? But of course, you want to have good hearing anyway, just to be able to communicate. So I'm going to stop there. We may have time for a couple of questions. Got one question up here.
With the positional vertigo.
So the question is, can benign paroxysmal positional vertigo, or BPPV, go along with graying out of vision and passing out? And I can think of a number of ways that could happen. First of all, yes, there are some people that are prone to fainting and in whom any kind of vertigo, any kind of strong sense of motion of the environment that's not actually moving, can trigger a faint. So some people are just predisposed to that. Secondly, you mentioned that hypothetically, what would happen if you jumped up out of bed and had vertigo? Could that trigger a faint? And I think just jumping up out of bed is a risky time in terms of fainting. If you're getting up out of bed, it may be first thing in the morning. That's an at-risk time for fainting. So I think the combination of the stress of the vertigo, the jumping out of bed, and the first thing in the morning makes it very plausible that somebody would be at risk for fainting, sure.
And just a follow-up question is that.
So is BPPV associated with motion sickness? Well, so some people get very nauseated with BPPV, and so some people are more sensitive to motion than others. And just like I was saying that I've seen BPPV that led into mal de Barkman syndrome, as though the motion signals from the ear from the BPPV represent for the brain an unusual kind of motion that then is not handled well and turns into MDDS. I think the same is true for motion sickness, that some people don't handle real physical motion that great and are very susceptible to nausea riding in the back seat of a car reading a book, or riding on a boat in turbulent waves. And those same people are susceptible to nausea with these abnormal signals that the ear is sending to the brain from BPPV. The question about, you mentioned lifelong motion sickness. So lifelong motion sickness doesn't really imply anything, but it is associated with migraine. So a lot of people with lifelong motion sickness also have migraine, and people with migraine are often people that don't do, well, not often, but sometimes people that have a harder time with BPPV. And this sometimes comes up with the treatment. So in order to do these Epley and similar maneuvers I was discussing, you have to put people in positions that trigger the vertigo. And if the goal is to move the debris around the canal and get it out of whatever canal it's trapped in, you have to move it around the canal, which triggers vertigo. And for some people, that can cause a lot of motion sickness. So in those cases, we sometimes have to pre-treat people with medication, like ask people to take meclizine or something similar a half hour before the maneuvers to make them more tolerable. And then you would also ask about, what about low blood pressure? To my knowledge, BPPV per se is not linked to or associated with low blood pressure, but migraine has been linked to low blood pressure, and migraine's been linked to dysautonomia. So to the extent that your question is really about migraine, there may be kind of like a mild dysautonomia of migraine, or maybe that's not the right word to use, because dysautonomia sounds like it's a real disorder, and for a lot of people with migraine, the autonomic phenomena that you see are relatively mild. They're not so severe that the dysautonomia features would actually cause the person to go to the doctor. They might go to the doctor for the headaches or the nausea or something else, but not for their chronic blood pressure of 90/60 or their, 2 faints that they had in college or something like that. So the autonomic features that you see in people with migraine are not usually that severe, but they can be. Yeah.
People that suffer from motion.
So I think the question is about the use of the scopolamine transdermal patch, which suppresses nausea and maybe vertigo, and it's used frequently on cruises, as you mentioned, to suppress motion sickness. It's very strong medicine, so it can dull your attention, it inhibits your balance. The question really was, do they have a role in vertigo? So the disorders that I talked about are treated with other things. So if you had very infrequent vertigo attacks from migraine, then let's say you had a vertigo attack once a month. You might not want to take a daily prescription medication that has side effects. You have very infrequent symptoms. You'd like to have something that you take as needed, once in a while. It might have a role in that setting, but I probably would prefer to start with something with less side effects first, like meclizine or something else, rather than scopolamine, just because it's so strong. But in theory, sure, I suppose it's another so-called vestibular suppressant. It suppresses dizzy and balance attack kind of sensations. Scopolamine, in theory, could have a role, but we limit use of it because of the side effects. And also the long-term side effects so the biggest problems with scopolamine are when you start using it every day for long periods of time. So I've seen people that did that and then they couldn't take the patch off because as soon as they take the patch off, they start getting dizzy and nauseated, and you get sort of dependent on it. But it's another issue. Yes?
Since there are so many different causes.
One of the questions was kind of like, well, there's a long list of possible contributors to dizziness. How do you know what's contributing? And I think you systematically make a list of all the plausible contributors and check each one and see if it's still plausible. And sometimes you come up with a list that has more than one item on it that's still plausible. And so sometimes you have to pick either whichever one seems more plausible, which is a little bit of clinical judgment, or sometimes it becomes a trial and error and just very good record keeping of what you've tried and what worked and what didn't work. Another way of framing your question is, well, can you have more than one of these things? And the answer is yes, all the time. I have patients all the time that have 2, 3, 4 of these things all at the same time. Like migraine and Menieres together is very common. Benign positional vertigo and migraine is pretty common. And sometimes there's a preferred order of treating things. Like I mentioned that I'd rather try to completely get rid of BPPV before adding migraine medicines, because then you're committing the person to a daily prescription med they might not need in a week from now, and which may have side effects. But there are exceptions. So some people say, no, my headaches and nausea are so terrible, you've got to add a migraine medicine, and then, okay, sometimes we do. But so, well, so the question is, who should see a dizzy patient first? And I mean, it's never the wrong answer to see your primary care doctor first, because there's also a long list of general medical causes of dizziness that I haven't addressed in this talk, with issues with the heart, the kidneys, that you could have low oxygen from a lung problem, you could have any endocrine, thyroid problems, diabetes, so I think primary care is not a bad idea. Some neurologists are more interested than others in dizziness. Otolaryngologists tend to get a lot of referrals for dizziness, and they're very comfortable with that, and they'll screen you for the ear issues. And if they decide, no, I don't think so, I think it's a neurological person, they'll send you to a neurologist. So I think any of those entry points would probably be okay: primary care, neurology, otolaryngology. Any other questions? Well, thank you very much for coming. Okay.